So my name is Chrissie Juliano. I run the Big Cities Health Coalition. Really excited to be here. My title is different than in your program because I can never decide on titles, and I literally sent it at the very last minute, and then Tuesday morning changed my mind. And I'm kind of glad that I wound up changing it because now I feel like I would have undermined everything that this panel said by the original title. But to me, the takeaway from all of these panelists, and again, I'll sort of walk through this, is core public health. All of the things that health departments do in responding to emergency preparedness are the things that they do every day. And sort of the rub for me and where these title issues happened is we talk about the emergency preparedness. We don't talk as much, we don't fund and we don't support the everyday work that really underlies that. So that's, again, what I'm going to try to touch on quickly so that we can all talk. So the Big Cities Health Coalition is 30 cities. The health departments that make up the coalition serve 62 million Americans, so not an insignificant amount of people. The coalition was founded in 2002 when Tom Frieden was the New York City Health Commissioner, Jonathan Fielding was in LA County, really around this idea that there's something unique and special about cities and about being city health leaders. So we've tried to carry on that tradition and founding over the years, and this is some of the work we do, and I will move on from there. So I wanted to share a couple of frameworks, because we are sitting at a School of Public Health, about how we think about some of these things. So this is an infographic that I worked on when I was at NATO with some colleagues there, the National Association of County and City Health Officials. And this looks at the key things that local health departments do. Emergency preparedness is up there, infectious disease is up there, immunization. Not meant to be separate, but really sort of draw this picture of the breadth of things that these local health departments need to address day in and day out. So this is funding for FEP, the Public Health Emergency Preparedness Program, and then there are two levels here. The green, I'm going to make sure I do this right, the green is FEP dollars that go to health departments. So it goes to the 50 state health departments, the territories, and 4 big cities. And then the blue on top are dollars that go to health systems in those same jurisdictions to prepare for preparedness, for emergency situations. So you can see, I don't think I need the laser to show you, that those dollars have really decreased over the years. They really ramped up after 9/11, and over the years they've fallen off. And again, that's where a lot of, particularly in public health departments, these capabilities are funded. So, and I should say that also came from my friends at NATO. I did not give credit on this slide, but this is from FANCY, the Public Health Center for Innovation. I always get the title wrong. I promise this is the last framework. But this is really thinking about sort of the point I was touching on. The top section here is really all the intangibles, all the infrastructure that health departments need to do, whether it's emergency or routine work. But we don't fund public health that way. We really fund the bottom here. We fund communicable disease, chronic, well, we don't really fund chronic, but we fund disease by disease. So, you know, as you've heard today, the vast majority of events have a local response, whether, again, they're routine or emergency. Again, most funding goes through the state. We don't really know in a lot of places how those dollars trickle down. So local health departments are really piecing together how they do this work. Really with cities, you know, you heard from Monica about the Boston Marathon bombing. There's this huge swath of people, not just the residents, but the people come in for these events. So, you know, they really need to think about being nimble. And then there's also this accountability piece. When you have a mayor and you have, whether it's a bombing or a snowstorm, you know, you report to that mayor, the mayor wants to know when you're going to fix it, and the residents want to know when the mayor's going to fix it. So there's really this hyper-local piece. And in many communities, the health commissioners, you know, really have this visibility and authority, I think, in many ways more pronounced than some of the state officials. So this is really where my head was when I put these slides together. So what's an emergency, and are they routine, right? I talked about failing to support the infrastructure by focusing on emergencies. But more and more, we have everyday emergencies. So one of the things that the coalition focuses on is gun violence. And so the difference between a mass shooting versus 30 people, I hate to say this, routinely being shot a weekend in a big city. So which is it? Is it emergency or the routine? Are they the same? Are they different? How to respond to that? How do we prevent that? So I really think the key is thinking about how we invest and build upon all of this so that we can respond when we need to and be prepared and prevent some of these more routine situations or emergency situations. So what I'm going to do now really quickly is walk through a couple of examples of things that I've heard from members over the past couple of years. So my job is really to facilitate members sharing their information and then share this stuff back with people like you, policymakers, so on and so forth. So I'm at like the 10,000 foot level. These guys are great. They're on the ground. They're responding in the weeds. But I'm going to share some takeaways from what I've learned from our members. So over the past couple of years, I guess about 18 months, there's been hepatitis A outbreaks in San Diego, LA, Seattle, Southeast Michigan. I just read about a new one yesterday and now escapes me. So these slides are from a webinar that BCHC and NATO did for members. So the left-hand side there is San Diego, the right-hand side is LA. And I know they're sort of hard to read. The key takeaway here is what San Diego talked about doing in their emergency response, again, is core public health. So they conducted surveillance. They did case investigations. They vaccinated. All of that was still part of this local health emergency and the governor declaring a state of emergency, but they did what they were trained to do, and they had the abilities to do that because of their everyday work. So similar in LA County, they activated their outbreak response plan and really talked about vaccinating and educating to prevent further spread of the outbreak. So this is, I want to pull up some details about this. This is a screenshot from a blog post on our Big Cities Health Coalition website from Patty Hayes from Seattle King County. So this blog post came out of Patty literally running up to me in a meeting and saying, our county executive is using risk dollars to prevent an outbreak. And I was like, what are you even saying to me, Patty? This is really great, but tell me the story. So Seattle King County first identified that they had one case, or they found one case, of hepatitis A in some homeless encampments that they have in April of 2019. So they immediately, again, do what they do. They deployed response and prevention strategies. And they talked with the county executive. Now, Seattle King County is unique. The health department serves both the city and the county, and they report to two people. They report to a mayor and a county executive, so it's sort of interesting. And so, you know, the health department sort of shared what was going on. They shared what happened in San Diego and LA and Southeast Michigan. And the King County executive allocated $375,000 from their loss control program, which in the county sits within the Office of Risk Management Services. So that office's job is to work with county agencies to identify areas of potential loss and recommend strategies to reduce exposure to liability. So the elected county executive recognized that if they had a major outbreak of hepatitis A, it was going to cost the county dollars and resources, and proactively said, take these dollars and do what you do. So we had Patty write a blog post about this, and the big quote on the left here is directly from the press release that the county executive put out, where he says, providing these vaccinations is an issue of equity, a prudent financial move, and a public health imperative. You know, we don't, without making too many sweeping generalizations, we don't get too many elected officials really standing up and having that strong public health message, and so we really wanted to raise this up. So measles in New York City, they just announced this week the outbreak is over, which was awesome. But again, they responded to this as an emergency, because it was an outbreak, with the same tools that we use every day. So This spring, we had Dr. Barbeau, the commissioner in New York City, write a blog post for Health Affairs about their experience. So I just wanted to share a few details from that. And the numbers that I'm going to share are through like April, May. So the numbers are probably are a bit off. So basically, from October to the spring, the New York City Health Department deployed 400 staff, including 70 disease detectives and 41 lab technicians. They administered 25,000 doses of measles, mumps, rubella, the MMR vaccine, to children younger than 19, which is almost 3 times as many as they normally do in that same time period. And the total cost of the outbreak in sort of time, staff time, and actual costs through May was $2.3 million. Now, New York City is New York City, right? So they have a little extra money lying around. But again, these are not things that we plan for, and we sort of need to think about moving forward what's not going to happen because of that measles outbreak. So opioids. Right? We talk about the epidemic, the crisis. Is it a chronic disease? Like, what is it? Well, we've been responding to and funding it like an emergency, although we've just started recently funding it, and thinking about what that response looks like on the ground. And so I think this is an example of responding in the moment, but then really having the opportunity to think big picture, okay, but what do we need to do to prevent the next wave of this epidemic, outbreak, chronic disease? I'm going to skip Zika because Lillian talked a little bit about it. But what I will say is that right after Lillian had her first handful of cases, she immediately got on the phone with her colleagues in the Big Cities Health Coalition, particularly the Texas folks, and said, here are like the 5 things you need to know today so that when you have your first case, you'll be prepared. So everybody really appreciated that, Lillian. So I'm just going to sort of close on this last issue of homelessness. So this is something that's come up a lot in the coalition recently, both in terms of addressing sort of core public health issues like hepatitis A outbreaks, but then also this bigger concept of housing, social determinants of health, and how does this all work together. So in July, 2 of our members, Seattle, King County, and then Long Beach, California, gave a presentation at NATO Annual that I moderated with them around what they're doing to address homelessness and what that really means like and looks like for a public health department. So this is the framework that Seattle, King County is doing, and they're, again, pulling in all those different pieces of the public health approach, healthcare, sanitation, prevention, and then really, supporting access to care, and then thinking about the policies and systems change that need to happen moving forward. And then this is a snapshot from the Long Beach presentation, and really I've put 2 slides together on here. But Kelly, who's the chair of the coalition and the health officer there, health director there, was talking about the different things, the different prevention and intervention pieces she does in her in their work on homelessness. And interestingly, her department is a health and human services department, so they also run homeless services. So, slightly different piece of the puzzle than some other health departments. But again, they're doing community engagement and planning, vaccinations, they're responding to outbreaks, they're doing outreach on HIV and STDs, they're doing core public health. So my totally disjointed examples here is really to say that we need to continue to support this basic hyper-local piece that health departments do. And I'm stealing this from a blog post from a former member of ours that I wrote with him. But this work that often goes unfunded is outreach to vulnerable populations, public health, risk communication, that are also all key parts to responding to emergencies. And we need to do a better job of funding it. And I'll take that up when I go back to DC later. But that's where I want to leave it, I think, for some discussion. And here is my contact info. So thank you.